Hello everyone, welcome to this recall session of the medicine questions asked in INI CET May 2024. So talking about the medicine questions overall, relatively a balanced paper, more representation from cardiology and endocrinology. And let's start the discussion of the questions. Moving on to the first question. This is regarding a 60-year-old diabetic patient who presents with symptoms of exertional dyspnea and pedal edema of 1 year duration. Auscultation revealed bilateral crepitations. Echocardiography shows reduced ejection fraction. Which of the following reduces the progression of heart disease in this patient? So we have got an elderly diabetic presenting with features suggestive of heart failure, and echocardiography is showing reduced ejection fraction. So we are dealing with a case of heart failure with reduced ejection fraction. Okay, so the clinical scenario given here is that of a heart failure with reduced ejection fraction. So what is the question? Which reduces the progression of heart disease in this patient? Is it option A, furosemide, option B, hydrochlorothiazide, option C, empagliflozin, option D, digoxin? So among the options, we have got 2 diuretics, then an SGLT2 inhibitor, and also digoxin. So in the chronic heart failure with reduced ejection fraction, I've taught you that the management is based on 4 pillars. This is very, very important. High yield point. What are the 4 pillars of management of heart failure with reduced ejection fraction? The first pillar and the most important one being ARNI, that is the angiotensin receptor blocker, neprilysin inhibitor, which is the sacubitril/valsartan combination. In the same pillar, you can also include ACE inhibitors. But if you compare ARNIs and ACE inhibitors, ARNIs are superior. The second pillar is the pillar of beta blockers, which includes either metoprolol, bisoprolol, and carvedilol. So you can use any of these drugs. Then you've got the mineralocorticoid receptor antagonist, and finally the SGLT2 inhibitors. So if you look at the options, out of this, the drug that reduces the progression of heart disease, what is the best answer here? It is empagliflozin, which is an SGLT2 inhibitor. Yes, you can use other drugs given in the options like diuretics, but they are mostly for symptom relief. So they do not have a definite proven mortality benefit, and they will not reduce the progression of heart disease. So in this question, answer is option C. Moving on to the next question. A 50-year-old patient with chronic heart failure with worsening dyspnea and uncontrolled diabetes mellitus, and they have given an HbA1c value of 7.8%, which is the preferred anti-diabetic drug. Again, this question also revolves around the concept of the pillars of the chronic heart failure management. And here is a patient with uncontrolled diabetes. And among the options, if you see the option dapagliflozin, this is actually, again, an SGLT2 inhibitor, which again will have a benefit not only in reducing the blood sugar levels, but also will prevent or retard the progression of heart failure as well. So the best option here is option D, dapagliflozin. Question number 3. In a diabetic patient with unexplained diarrhea, which drug is most likely to be implicated? So what do you think? Is it metformin, sitagliptin, glimepiride, or pioglitazone? So unexplained diarrhea. Well, this can happen as a side effect of metformin. Okay, metformin can produce unexplained diarrhea. Is it common? No, it is not that common. But still, yes, there is a possibility that metformin can produce GI adverse effects. Okay, but let me repeat again, this is not so common in practice. But theoretically, when we discuss, metformin-induced diarrhea is mainly due to changes in the gut microbiome, increased intestinal glucose and bile acid turnover, and increased GLP-1 concentration, right? And a decreased ileal bile salt reabsorption can enhance the secretory effect of bile salts in the colon, and that can also contribute to enhancing the GI motility. And most often, this side effect of metformin, that is the GI side effects, they often occur in the initial part of treatment. But what happens is that after the initial few doses, it is unlikely that the patient continues to have the side effect. But very rare scenarios, the diarrhea may persist. So that is why, when you have a patient on metformin, if you have got a chronic diarrhea, this is one possibility that you can consider. Okay, so let's move to the next option. All the following are criteria for the diagnosis of diabetic ketoacidosis except. So again, diabetic ketoacidosis is a very important topic for your exams. And either you get factual questions from this topic, or it may be a scenario-based question as well. But here they have asked about the diagnostic criteria. Let us go through the options. Serum glucose more than 250 milligram per deciliter. That's option A. Option B, pH less than 7.3. Option C, serum bicarbonate less than 15 milliequivalents per liter. Option D, serum potassium less than 3.5 milliequivalents per liter. So let us see the commonly used criteria for the diagnosis of diabetic ketoacidosis. Number one, it is diabetic ketoacidosis. So what should be there? Hyperglycemia should be there. And the serum glucose should definitely be more than 250 milligram percentage. It is unlikely for a patient with sugars below that level to develop a diabetic ketoacidosis. And yes, it is acidosis. So the arterial pH will be less than 7.3. Point number 3, the serum bicarbonate level will be less than 15 milliequivalents per liter. So there is acidosis. Then presence of ketonemia or ketonuria. And then finally, high anion gap. So the normal anion gap, the upper limit is around 12. So in high anion gap metabolic acidosis, the anion gap will be about 12. It's a high anion gap metabolic acidosis. Let's look at the options. Option A is a part of the criteria. Option B is also a part of the criteria. Option C is also a part of the criteria. Now, what about option D? Serum potassium less than 3.5 milliequivalents per liter. Well, you have to understand some basic points here. First of all, in the setting of a DKA, when the patient presents to the clinician, please understand, look at this interesting point from Harrison. Despite a total body potassium deficit, the serum potassium at presentation may be mildly elevated. And why is it so? Secondary to the acidosis and volume depletion. So what you expect is that at presentation, diabetic ketoacidosis patients can have a mildly elevated potassium levels. Now, can hypokalemia occur in the setting of diabetic ketoacidosis? It is possible. In what all ways? Number one, insulin-mediated potassium transport into cells. So once you start treatment of diabetic ketoacidosis with insulin infusion, this insulin can cause redistribution of potassium from the extracellular fluid to the intracellular fluid. That can cause hypokalemia. Number two, resolution of acidosis. So as you correct acidosis in the management of DKA, this will also promote the potassium entry into the cells. And that can also cause hypokalemia. And then urinary loss of potassium salts of organic acids. So these are the three scenarios where hypokalemia occur in DKA. But something is very obvious. And what is that? hypokalemia in decay mostly happens as a part of treatment. Yes, you will have to anticipate hypokalemia in decay, and that is during the treatment part. Correct? So, if you look at the options here, option D is not a part of the diagnostic criteria, and hypokalemia usually happens during treatment of diabetic ketoacidosis. Answer is option D. Okay, let's go to the next question. A 45-year-old man presents to the outpatient department with proximal muscle weakness, purple stretch marks, obesity, and EC bruising. What is the underlying condition? Is it hyperthyroidism, hyperparathyroidism, hypercortisolism, or is it hyperaldosteronism? So, a middle-aged man with a constellation of symptoms. And these constellation of symptoms, I think quite evidently is pointing towards hypercortisolism. Okay, hypercortisolism. Now, I think we'll just quickly scan through this very important table in Harrison, which I have highlighted in my lectures as well. What are the clinical features of Cushing syndrome? Now, I have just highlighted from this table on the points asked in this question. Number one, weight gain is there, especially you've got a central obesity. EC bruising is a feature. Purple stretch marks, which you can see in the image given as well. And you can have weakness. Yes, which is often a proximal myopathy. So these are all features of hypercortisolism. So the impact of hypercortisolism is multi-system. You've got affection involving the body fat, skin, bone, muscles, cardiovascular system. It affects the metabolism, reproductive system, central nervous system, and the blood and immune system as well. So all the constellation of findings are important. But in this question, it is a simple, straightforward question that is answer with option C, hypercortisolism. Okay, right. Moving to the next question. Which of the following anti-diabetic agents is associated with increased risk of urinary tract infection? So once again, I'm reminding you how important diabetes is for your exams, be it INI CET or NEET PG. You can get questions from the medicine angle, and sometimes even the core pharmacology, pharmacotherapy of diabetes as well. So please learn diabetes topic well. I've covered in detail in my lectures as well. Okay. So what are the options here? You've got sitagliptin, pioglitazone, dapagliflozin, and metformin. So again, I've highlighted in my lectures, SGLT2 inhibitors, they can have an increased risk of urinary tract infections. Okay. So just for reference here, you can see that with the use of SGLT2 inhibitors, urinary and genital mycotic infections are more common in both males and females. So that would make the answer option C. Okay, right. Next question. Which of the following is an adverse effect of long-term intermittent teriparatide for the treatment of osteoporosis? Is it subtrochanteric fracture, loss of bone mass, osteosarcoma, or osteonecrosis of the jaw? So teriparatide is often used in the treatment of osteoporosis. But the point that the examiner is trying to ask you is on an important adverse effect that can occur when a patient takes teriparatide for a longer duration. So look at this reference from Harrison. There are several rodent studies that actually show that prolonged treatment with PTH that can result in osteogenic sarcoma. And because of such reports, you can see that the FDA has limited the teriparatide treatment to 2 years. Why? Because beyond that period, there is a risk of development of osteosarcoma. So 2 years is the maximal duration. So long term, beyond that, there is a chance of osteosarcoma. And let me also just add on osteonecrosis of the jaw. This is actually a side effect of bisphosphonates. Okay, this also is a PYQ. Okay, bisphosphonates. Okay, bisphosphonates can result in osteonecrosis of the jaw. Okay, let's go to the next question. Again, a very simple, straightforward question. Which of the following causes a decrease in the serum parathyroid hormone? Is it calcitriol, furosemide, lithium, or risedronate? See, calcium homeostasis, I've covered in my lectures in the module on hypocalcemia and hypercalcemia. And the simple basic fact that when you have got calcitriol, okay, calcitriol can cause a decrease or can inhibit the production of parathyroid hormone. So answer is calcitriol, option A. This one again, relatively a simple question. All you've got to do is to analyze the question properly and come up with the diagnosis. A 10-year-old boy presented with follicular tonsillitis. He was prescribed antibiotics, and after a few days, the patient developed decreased urine output, rash, and periorbital edema. Peripheral smear shows eosinophilia, and urine microscopy shows WBC cast. What is the likely diagnosis? So there was a primary diagnosis of follicular tonsillitis, and following antibiotics, the patient developed certain symptoms. So there is a temporal association between antibiotic intake and the symptoms that the patient developed, that is decreased urine output, rash, and periorbital edema. So decreased urine output and periorbital edema makes us think that there is a problem in the kidney. And interestingly, there are certain unique features as well. One is rash, peripheral blood smear showing eosinophilia, and urine microscopy showing WBC cast. So what are the options that we have got here? Pyelonephritis, allergic interstitial nephritis, urinary tract infection, and Berger disease. So if you look at the option, if you analyze the question, this is the classical presentation of an allergic interstitial nephritis, option B. So how does allergic interstitial nephritis present? The classical presentation of an allergic interstitial nephritis is with fever, rash, peripheral eosinophilia, and oliguria kidney injury. So when you have got a renal affection with rash and peripheral eosinophilia, you have to think of acute interstitial nephritis, also known as allergic interstitial nephritis. The urine analysis will show pyuria with WBC cast and hematuria, which may be there. Then urinary eosinophils, please understand they are neither sensitive nor specific for AIN. Okay. Now, what are the drugs that are implicated in the genesis of allergic interstitial nephritis? Mainly the category of antibiotics, beta-lactams, sulfonamides, quinolones, vancomycin, erythromycin, linezolid, minocycline, rifampicin, ethambutol, acyclovir, non-steroidal anti-inflammatory drugs and COX-2 inhibitors, diuretics. You've got rarely the thiazide drugs. Then you've got the loop diuretics and triamterene. Then anticonvulsants like phenytoin, valproate, carbamazepine, and phenobarbital, and other drugs like PPIs, the H2 blockers, captopril, mesalazine, indinavir, allopurinol, and linalodomide. But I think you are supposed to know, especially the antibiotics that can cause allergic interstitial nephritis and NSAIDs. So probably what happened in this scenario is that the patient took an antibiotic for follicular tonsillitis and maybe antibiotic which can cause allergic interstitial nephritis like beta-lactams, and following which he developed all these symptoms of renal involvement. Okay, so please understand that this is the classical presentation of allergic interstitial nephritis, and it's not that all cases would present in this manner. You can have an NSAID-induced acute kidney injury presenting with raised serum creatinine and oliguria without any rash or maybe even a peripheral smear eosinophilia as well. So you can have atypical presentations of allergic interstitial nephritis as well. So you've got to maintain a good index of suspicion. So here answer is option B. Choose the incorrect statement about renal tubular acidosis. Again, a very high topic for INI CET exams. You definitely will get questions based on RTA, acid-base balance, very, very important. So the options are mainly focusing about type 2 RTA and type 4 RTA. Option A says type 2 RTA may be associated with bicarbonaturia. Option B says RTA type 4 is associated with hypokalemia. Option C, RTA type 2 may present with Fanconi syndrome. And option D, RTA 4 is due to aldosterone resistance. The first one is correct. RTA 2 may be associated with bicarbonaturia because RTA type 2 or the proximal RTA is causing dysfunction of the PCT, where you have got normally the reabsorption of bicarbonate, which is not happening, and there is bicarbonaturia. But remember, RTA type 4 is the hyperkalemic distal RTA. Remember, that's the other name of RTA type 4, which I've told you in my lectures as well. RTA type 4 is a hyperkalemic one. Okay, so that is an incorrect statement. Let us look at the other options. Yes, RTA type 2 can present with Fanconi syndrome. What is Fanconi syndrome? It's actually a more generalized proximal tubular dysfunction, wherein you can have glucosuria, aminoaciduria, phosphaturia. So more, widespread dysfunction of the proximal convoluted tubule happens in case of Fanconi syndrome. And the last option, RTA type 4, is due to aldosterone resistance, is also a true statement. So the answer for this is going to be option B. Okay. Next question, 35-year-old patient presents with nausea, vomiting, diarrhea. ABG results indicate pH of 7.55, PaCO2 of 50, and bicarbonate of 44. What is the acid-base disturbance? So if you put the arrows, pH on the higher side, PaCO2 on the higher side, and bicarbonate also on the higher side. Yes. So we know that the normal values of the pH is around 7.4, PaCO2 is around 40, and bicarbonate is around 24. So since it is an alkalosis, and if you look at the direction, the change in pH in relation to the change in PaCO2 and bicarbonate is in the same direction. Okay, is in the same direction. So what is happening here? It is actually a metabolic alkalosis. Okay, metabolic alkalosis. So it is an alkalosis, and since the arrows are going in the same direction, it is a metabolic alkalosis. Okay, right. So option D is the answer, and let's go to the next question. A patient presented to the emergency department with abdominal pain, vomiting, tachypnea, and tachycardia. Lab reports are shown below. pH 7.34, sodium 135, potassium 5 milliequivalents per liter, bicarbonate 12 milliequivalents per liter, chloride 92, and RDS 450. So the scenario is that of a patient with a hyperglycemic crisis, with a high blood sugar, presenting with abdominal pain, vomiting, and tachypnea, tachycardia, with acidosis. So scenario based itself, you are thinking of a diabetic ketoacidosis, and diabetic ketoacidosis is characterized by a metabolic acidosis, which is a high anion gap metabolic acidosis. So it is not going to be respiratory acidosis. It is not going to be a metabolic alkalosis. It is metabolic acidosis. And I think even you can calculate the anion gap here, which is 135 minus 92 plus 12, which is 104. So definitely it is the anion gap is coming around 31, which is a high anion gap metabolic acidosis. Okay, so any anion gap which is more than 12, you will say that this is a high anion gap metabolic acidosis. So answer is option B here, high anion gap metabolic acidosis, right? Let's go to the next question. So next question, erythropoietin is produced by, is it liver, spleen, kidney, or lungs? So we know that the major site of erythropoietin production is the kidneys. where you have got the peritubular capillaries. And in the peritubular capillaries, you have got certain interstitial fibroblast, and they will produce erythropoietin. So that is going to be the best answer here. Erythropoietin is produced by answer kidney. Option C is the answer. Okay, right. The next question, 55-year-old male presented with acute onset chest pain to the emergency department. ECG was taken, and what is the likely diagnosis? So look at the options: unstable angina, non-ST elevation MI, posterior wall MI, and acute myocarditis. And I assume that a similar ECG was asked in the exam, wherein the ECG findings were showing the ST depressions in leads V2, V3, and V4. Now, you've got to be a bit careful here. See, if you look at the options, unstable angina, non-ST elevation MI, see, these two options, they actually have similar ECG findings. And it is only based on the cardiac biomarkers you can differentiate between them. And you cannot differentiate between these two options based on ECG alone. So I am not considering that as a top priority now. Now, coming to posterior wall MI. Now, this is something which all of you should know. What are the ECG findings in case of a posterior wall MI? So the basic point here is that the posterior myocardium is not directly visualized by the standard 12-lead ECG. But in a posterior wall myocardial infarction, you can get reciprocal changes of the ST elevation MI. So in the anteroseptal leads, so especially in the leads V1 to V3, you may get reciprocal changes. Okay. And understand that most often the posterior wall myocardial infarction that occurs in combination with inferior wall myocardial infarction. So the ST elevation MI that is involving the inferior wall, that again usually has, when you get a posterior wall MI, this is usually in combination with the inferior wall MI, but sometimes and rarely you can have isolated posterior wall MI as well. So if you look at the leads 2, 3, and AVF, I'm not able to identify a definite ST segment elevation. If that was the case, it would have made things a lot easier, because we know that most often the posterior wall MI will coexist with the inferior wall MI. Okay. But herein, this is likely to be a isolated posterior wall MI. And what are the expected ECG changes? Number one, you may get a horizontal ST segment depression. Number two, tall, broad R waves, upright T waves, and a dominant R wave. The R by S ratio will be more than 1 in leads like V2. So if you look at the lead V2, you can definitely spot that the R is more than that of S. Yes or no? So we are probably thinking of a posterior wall myocardial infarction here. And you should understand that the reason for this, because the posterior wall has a relatively lesser representation. So the typical injury pattern of an ST elevation involving the posterior wall, you will have reciprocal changes only, because whatever is the ST elevation will be manifested as an ST depression in the anteroseptal leads. Instead of the Q wave, you will see R wave, and the terminal T wave inversion will become an upright T waves as well. So if you look at the ECG, yes, there is a horizontal ST segment depression. The R by S is more than 2, and you are having an upright T wave as well, which makes me think of the diagnosis of posterior wall myocardial infarction. It is less likely to be acute myocarditis, because that is not correlating with the findings here. Acute myocarditis can have either sinus tachycardia or certain non-specific STT changes, but without any history suggestive of development of myocarditis with this isolated ECG finding, you cannot be making a diagnosis of acute myocarditis, but this is likely to be an isolated posterior wall myocardial infarction. Option C is the answer. Let us go to the next question. A patient presented to the emergency department in a drowsy state, and he was in hypotension, and ECG revealed narrow complex tachycardia what is the next best step in management. So a narrow complex tachycardia with hypotension. Okay, definitely you have to give shock to the patient. The patient is in shock and you will have to give a DC shock, which is a synchronized DC cardioversion. And what could be the reason for the drowsy state? Maybe the cerebral hypoperfusion might have resulted in a hypoxic encephalopathy, and that would have been the reason for the altered sensorium as well. So here, what is going to be the answer? It is a synchronized DC cardioversion. What about options B and C? Yes, it can be given in a narrow complex tachycardia, but with the patient hemodynamically unstable, that is not going to be the next best step. You will have to go for a synchronized DC cardioversion. Okay, right. Answer is option A. And what about IV amiodarone bolus? Remember, that is not for narrow complex tachycardia. It is for wide complex tachycardia that you give amiodarone. Okay, right. Next question. A 45-year-old female presents to the emergency department with breathlessness. She was having tachycardia with a blood pressure of 100 on 70 mmHg. She had a viral infection followed by a chest pain 7 days ago, and the chest X-ray revealed a water bottle sign. Which of the following statements? All are true except, so you have to pick up the false statement. So look at this. Patient has presented with breathlessness. Okay, so a middle-aged female with breathlessness, tachycardia, and patient is in a bit of hypotension. And what could be the reason for this? In the question, there is an evidence of viral infection followed by chest pain. So probably there was a pericarditis following a viral infection. Chest X-ray revealed a water bottle sign, which is seen in pericardial effusion. So most likely the pericarditis might have resulted in a pericardial effusion. And what could be the reason for breathlessness? So probably it is a rapidly accumulating effusion, which might have resulted in a tamponade, cardiac tamponade. So that is the likely scenario that we are dealing with. Let us see the options. Option A, pulsus paradoxus may be seen. Option B, loud S1 is expected. Option C, emergency pericardiocentesis may be required. And option D, ECG may show a diastolic collapse of the right atrium and right ventricle. So first option, pulsus paradoxus may be seen. It is a true statement. Yes, in case of cardiac tamponade, you can have pulsus paradoxus. Pulsus paradoxus can have multiple etiologies. One among them is going to be cardiac tamponade. Okay, right. So emergency pericardiocentesis may be required, true, because this is an emergency. And ECG showing diastolic collapse of the RA and RV, the right atrium and right ventricle, is also a true statement. So all these three statements are true and is not going to be the answer. They want you to identify the false statement. With such amount of fluid surrounding the heart, do you think you're going to get a loud S1? The S1 is going to be very much soft and muffled. So what is going to be the answer? Answer is option B. Loud S1 is expected. Let's go to the next question. Which of the following statements is false regarding a 35-year-old male presenting to the emergency department with unconsciousness and ECG showing atrial fibrillation? So I assume that a similar ECG was shown in the exam as well. So from the recall that I got from the students, they told that it was already mentioned in the question that the patient is having atrial fibrillation. So it seems that they did not trouble you regarding the identification. But again, look at the rhythm strip, that is lead 2, will tell you that we are discussing or we are dealing with a narrow complex tachycardia, which is irregular with absent P waves. So we are probably thinking of atrial fibrillation. Okay, so let us see the options. So they're asking which of the following statements is false. Some students gave me a different version of this question. They told me that, sir, it was which of the following is true. And again, the options were, slightly twisted again. So I do not know what exactly was the question, but again, we'll discuss the points so that you're clear on the concepts. Option number one, rare occurrence in individuals with normal heart. Well, AF can occur in patients with structurally abnormal heart as well as structurally normal heart. More common in patients with structurally abnormal heart, correct? But it can occur in other conditions as well. So I would say that that statement is true. So it is relatively rare compared to the other conditions. DC cardioversion must be done for all cases. Okay, DC cardioversion must be done for all cases. See, in case of atrial fibrillation, you will go for DC cardioversion only if the patient is in shock. Hemodynamically stable patient is not a definite indication for cardioversion. You can try the medical treatment first. IV digoxin for rate control is also a true statement. Discrepancy in heart rate and pulse rate can be used for supporting the diagnosis. That is also a true statement. If that is the case, the false statement is this: direct cardioversion must be done for all cases. Now, some other students told me a different version. They said, sir, we have to choose the true statement. And one option that was that it can occur in individuals with normal heart, which then will be a true statement. And the others, where they said that the options were slightly different. For example, they said discrepancy of heart rate and pulse rate, which is your pulse apex deficit, is 100% necessary for making a diagnosis. So this happens every year where you get different recalls of or different versions of the recalls of a question. And as a faculty, I'm just trying to give you the basic concept so that you understand the topic well. Okay, so if this is the correct framing of the question, the answer is option B, right? Let's go to the next question. Which is not correct about high quality CPR? Chest compressions 100 to 120 per minute is option A. Chest compressions at 3 to 4 centimeter depth. Next option, allow complete chest recoil, and compression ventilation ratio is 30:2. What about option A? Absolutely correct. 100 to 120. Okay. Chest compressions 3 to 4, not correct. What is it? It is actually 5 to 6 now. It is 5 to 6 centimeter. You cannot make a mistake on that. Answer is option B. Allow just complete chest recoil, correct. Compression ventilation ratio is 30:2, correct. So answer is option B, right. Next question. Which of the following drugs can be safely used in a patient with enterococcal endocarditis with penicillin allergy? Ceftriaxone, aztreonam, piperacillin, vancomycin. Only if you are well read in this topic, you will be able to answer this. We have covered the topic of infective endocarditis in detail in our lectures, including the latest treatment guidelines. So let us just quickly go through this from Harrison on the treatment of enterococcal endocarditis. So you can go for ampicillin plus ceftriaxone in this condition of enterococcal endocarditis, but they have specifically said that the patient is having penicillin allergy, so I cannot be giving this patient ampicillin. Now, what is the other option that I've got? The next option that I've got is vancomycin. Yes, you can go for vancomycin, which is effective, and you can give it in combination with an aminoglycoside as well. So among the options, if you look, vancomycin is a good alternative in a patient with penicillin allergy. And if the patient is allergic to vancomycin as well, then you can think of other agents like, say, combination of daptomycin plus aminoglycoside, linezolid. These are the other options that you have got, and even quinipristine, dalfapristine combination as well. So in this question, answer is going to be option D. Next question, a 40-year-old male is admitted to the medicine department with complaints of recurrent episodes of vomiting and diarrhea. On lab evaluation, the serum potassium was 3 milliequivalents per liter. All the following are possible complications except. So The scenario is given with the patient ending up in a hypokalemia. So they're asking about the complications of hypokalemia. So let us see the options. Number one, quadriplegia can be a complication because hypokalemia can result in paraparesis or paraplegia or quadriparesis or quadriplegia depending on the severity of hypokalemia. Remember, I've taught you about hypokalemic periodic paralysis, which can be primary or secondary. A primary hypokalemic periodic paralysis can happen when there is a mutation involving a calcium channel. Okay, hypokalemic periodic paralysis, calcium channel mutation. You can have a secondary hypokalemic periodic paralysis in patients having thyrotoxicosis. Okay, thyrotoxicosis is one cause of a secondary hypokalemic periodic paralysis where you can have a redistribution of potassium. And you can also have secondary hypokalemic periodic paralysis due to other conditions. For example, severe vomiting and diarrhea resulting in a severe electrolyte imbalance and hypokalemia. And quadriplegia can be there, so I'm not going to pick that as the answer. I'm eliminating it. Ventricular tachyarrhythmias, definitely possible. Diabetic insipidus is also possible because it can cause resistance to the action of ADH. And cerebral edema is not due to a potassium abnormality. It is usually a consequence of sodium abnormality. Okay, so you can have a cerebral edema maybe as a result of hyponatremia and not hypokalemia. Okay, even hypernatremia also can result in cerebral edema as well. Okay, so answer is option C for this question. Okay, right. Which drug used in the treatment of leprosy can result in hyperpigmentation? Very simple question. It is clofazimine, option C. And for reference, I'm just giving you two very important side effects of clofazimine, which you should be aware of. Number one is a skin discoloration. This usually fades within 6 to 12 months of clofazimine discontinuation. And another feature is the ichthyosis. Okay, the skin discoloration, hyperpigmentation, and ichthyosis are two important side effects that you should know regarding clofazimine. Option C is the answer. Next question, a 45-year-old male presents with complaints of excessive daytime sleepiness. His wife also reports that he snores a lot at the night. Choose the incorrect statement regarding this condition. So excessive daytime sleepiness with snoring in the night. What is the probable diagnosis that you're thinking about? Could be obstructive sleep apnea, OSA. Obstructive sleep apnea is the likely diagnosis. And they're asking about incorrect statement regarding obstructive sleep apnea. Fall in oxygen saturation triggers waking up at night. Absolutely correct. So I'm not going to pick that as the answer. Increased tone of pharyngeal muscles worsens the obstruction, which is wrong. You know that it is not increased tone. It is actually a decreased tone, a fall in the tone in the region of pharyngeal muscles. So answer is option B. If you look at other options, low oxygen stimulates respiratory effort is a true statement. Apneic episodes increases the stress on the heart, which is also true because obstructive sleep apnea has a significant impact on the cardiovascular system, resulting in increased cardiovascular adverse events and also hypertension as well. Okay, so answer is option B. Which among the following is not a common cause of chronic bipedal edema? Chronic liver disease, nephrotic syndrome, chronic venous insufficiency, lupus nephritis. So all of you very well know that chronic liver disease can cause bipedal edema, chronic bipedal edema. Nephrotic syndrome possible. What about lupus nephritis? Lupus nephritis can present with either a nephritic syndrome or nephrotic syndrome. You know that class 3 lupus nephritis, class 4 lupus nephritis with predominant glomerular involvement can present with edema, possible. So that can also result in bipedal edema. So I'm eliminating these three options. And what is a chronic venous insufficiency? So chronic venous insufficiency is often a consequence of incompetent veins, wherein you get venous hypertension and extravasation of fluid. The causes of chronic venous insufficiency include varicose veins and a disease in the deep veins. You have got either varicose veins resulting in a venous insufficiency or a disease involving the deep venous system. It can be a primary deep venous insufficiency or a secondary deep venous insufficiency. Primary deep venous insufficiency, wherein you have got an intrinsic structural or functional abnormality in the vein wall or venous valves leading on to a valvular reflex. A secondary deep venous insufficiency where there is obstruction or valvular incompetence from a previous deep venous thrombosis. Now, can chronic venous insufficiency cause pedal edema? Possible. Can it cause chronic pedal edema? Possible. Can it cause bipedal edema? Possible, but it is more commonly unilateral. Okay, so all these venous problems, they are commonly unilateral, but can very well be bilateral as well. So among the options, I feel this would be the best option to pick to answer. Okay, right. Next, all the following scenarios would warrant an extensive evaluation for headache etiology except. So headache etiology extensive evaluation is when you think of a secondary headache, because primary headaches are mostly clinical diagnosis. If at all you do an imaging, it is to rule out any other close mimicus. Okay, you're not expecting significant imaging changes in tension type headache or migraine or the trigeminal autonomic cephalalgias, but secondary headache you have to watch out for. Now look at the options. The first option, first onset at 50 years of age. So a patient who never had significant headache till 50 years, now having new onset headache definitely has to be evaluated. No doubt about it. Okay, it warrants extensive evaluation. Temporal artery tenderness, again, especially if it is elderly, you should be thinking of a possibility of giant cell arteritis. Subacute progression over 4 weeks, especially if the headache is progressing. Could this be a space occupying lesion? What could be the reason be? So that also requires extensive evaluation. Cocaine use, well, cocaine use, can it produce headache? It can produce headache. If you look at the CNS impact of cocaine abuse, cocaine can affect multiple systems, but when it comes to the central nervous system, it can cause headache, it can cause seizures, stroke, and cognitive impairment. It can have acute impact as well as chronic impact on the central nervous system. But you are not going to get anything with extensive evaluation, right? So obviously cocaine can cause a headache, no doubt about it, but what additional extensive evaluation you require for that? Nothing. And just to substantiate my point that this could be the best answer, this is one table in Harrison listing the headache symptoms that suggest a serious underlying disorder, where you can see that when a patient has a sudden onset severe headache, a first severe headache, worst headache ever, a vomiting that precedes the headache, subacute worsening over days or weeks, pain induced by bending, lifting, or coughing, pain that disturbs the sleep or presents immediately upon awakening, known systemic illness, onset after the age of 55 years, fever or unexplained systemic signs, abnormal neurological examination, and the pain associated with local tenderness in the region of temporal artery, please do extensive evaluation. So the best answer for this is going to be option D, cocaine use. Okay, right. The next question, I think again something very important and is the latest update as well. Cannabidiol is not approved for the treatment of. Is it Lennox-Gastaut syndrome, tuberous sclerosis? And I think, I've written tuberous sclerosis twice here, but actually the third option was Dravet syndrome. Okay, Dravet syndrome. The actual exam did not have tuberous sclerosis being repeated. So this is my mistake while typing. So it is Dravet syndrome, and the final option was Rett syndrome. So cannabidiol is again, okay, it's a drug. Okay, it is not having any psychoactive properties of cannabis, so don't worry. So this is available as an oral solution without any psychoactive properties that I told you. And this will enhance the GABA action through allosteric modulation of the GABA A receptor. And this is important, especially in epilepsy. So always remember, cannabidiol is a new drug in the kitty available as an oral solution for certain epilepsy syndromes. And what are those certain epilepsy syndromes? Number one, Lennox-Gastaut syndrome. Number two, Dravet syndrome. And number three, tuberous sclerosis. So these are the conditions for which it is used, and you're not going to be using it for Rett syndrome. No. Okay, right. Next question, the representation shown below is suggestive of. So REM sleep and NREM sleep, important. They have given the polysomnographic representation involving the EEG, EOG, and EMG. And from what I understood from the students is that the EMG was showing a more or less flat line. Okay, so there was atonia. And when you get REM atonia, heard of REM atonia? That is why the EMG is showing atonia. It was more or less a flat line. And since the EMG was showing evidence of atonia, I am thinking of the REM sleep as the answer here, because none of the other three stages of sleep is going to have a flat line for the EMG. Okay, so answer is REM sleep. Okay, right. Answer is option D. Next question, in comparison with ulcerative colitis, choose the true statement about Crohn's disease. So always hot topic, comparison between Crohn's and ulcerative. So let us look at the options. Continuous pattern of involvement rather than skip lesions. It's option A. They're asking about true statement about Crohn's. Do you think it's a true statement? Absolutely wrong, because skip lesions are more common with Crohn's disease. That's a common pattern. Commonly manifest with hematochezia. Again, false statement. It's not a common manifestation, hematochezia. Okay, patient can have features of malabsorption in Crohn's disease. No increased risk of colon cancer. Well, there is increased risk of colon cancer, especially if it is Crohn's having a colonic involvement. You cannot say that there is no increased risk. Yes, ulcerative colitis has slightly more risk, but if it is a Crohn's disease with a colon involvement, you do have increased risk of colon cancer. And what about last option? Perianal fistulas are frequent. Yes, it is true. Perianal fistulas are frequent in case of Crohn's disease. So if you look at this table, again, showing the differences between Crohn's and ulcerative colitis, you can see, number one, the bowel region involvement. It's involving ileum plus or minus colon in Crohn's, whereas it is restricted to the colon mostly in case of ulcerative colitis. As I told you, skip lesions in Crohn's disease and diffuse pattern of continuous involvement in ulcerative colitis. Strictures more common in Crohn's disease. The wall is thick and edematous in case of Crohn's compared to ulcerative colitis, because you get a transmural inflammation. In Crohn's, what you get is a transmural inflammation. Transmural inflammation. Then coming to the microscopic involvement, as I said, you will have an inflammation extending through all the layers. So it is transmural. Ulcerative is mostly limited to the mucosa. At max, it can go to the submucosa. Pseudopolyps can be seen in both, but more marked in ulcerative colitis. Ulcers can occur in both, but in Crohn's disease, you get deep knife-like ulcers. In ulcerative colitis, you get superficial broad-based ulcers. Marked lymphoid reaction in Crohn's disease and moderate in case of ulcerative colitis. Fibrosis and serositis, again, more marked in case of Crohn's. Granulomas are present in Crohn's. Fistulas are a feature of Crohn's disease. Perianal fistula, yes, in Crohn's disease. No, in case of ulcerative colitis. Malabsorption, more common in case of Crohn's. Malignant potential, more in ulcerative, but even in Crohn's with colonic involvement can have malignant potential. Recurrence after surgery is common with Crohn's. Toxic megacolon, again, is more common with ulcerative colitis. So if you look at the options here, it is perianal fistulas that are more prominent in case of Crohn's disease. That will be my answer. Okay, right. So let's go to the next question. For this question also, I got different versions of the question. So I can only give you an overview of this. A 60-year-old male who is a chronic alcoholic presented to the emergency department with multiple bouts of vomiting and altered sensorium. His previous binge of alcohol was 7 days ago. He was in hypotension when he came to the emergency department. Okay. So what could this be? Well, could this be vernix encephalopathy? Possible. It could be vernix encephalopathy, patients with vomiting, altered sensorium. Okay. But again, you've got other possibilities because you've got possibilities like hepatic encephalopathy as well. Okay, let's see. Ultrasound. Ultrasound shows a small liver with coarse echo texture and portal vein dilatation. So if they're giving that data means they're telling you this is probably a hepatic encephalopathy. That's otherwise they would not have given that. So can't a patient with CLD develop vernix encephalopathy? Possible. But since this is actually given there as a data, you should think about hepatic encephalopathy as a possibility, a decompensated chronic liver disease resulting in hepatic encephalopathy. Okay, so what are the options here? Administer lactulose, perform endoscopy to assess for varices, initiate treatment with thiamine and chlordiazepoxide and do a CT brain. Well, again, let me tell you, the answer for this will depend on the exact wordings of the question. I'll be very honest with you. A small twist or turn in the question can change the answer. I'll tell you why. Now, if this is the version, if this exactly is the version, I am more tempted towards writing administering lactulose because this is a hepatic encephalopathy and I want to treat the encephalopathy. So I'll be giving the patient definitely lactulose. Okay, not endoscopy because that is not my first step. See, already the patient has come in a critical stage. So I should first try to stabilize the patient before any other evaluation. So I'm not thinking of this one. What about thiamine and chlordiazepoxide? Thiamine, chlordiazepoxide, this combination is given for delirium tremens. And I am not thinking of delirium tremens here because then they would have said a history of not 7 days, maybe in the duration of 48 to 96 hours. Maybe that would have been the duration. And the other symptoms are also, more suggestive of the hepatic encephalopathy rather than a delirium tremens for this. So, I'm just eliminating that question. If you ask me, sir, don't we have to give thiamine? Has to be given, guys. But again, I'm trying to pick up what is the best possible answer here. Do CT brain. Well, doing a CT brain is also important. I'll tell you why. See, how sure are you that this is exactly hepatic encephalopathy? I'll tell you in actual practice, if a patient comes like this with altered sensorium, before you shift the patient from the emergency to the ward or ICU, come what may, you will have to do an imaging just to rule out other causes, not to, see if, not to substantiate the first diagnosis you're thinking about, but again, to rule out other causes. This can be anything, right? Maybe the CLD patient would have developed a thrombocytopenia. Subsequently, he developed a subdural hemorrhage, possible. So it is important to do a CT brain. So I exactly do not know what exactly was the framing, but if this is the framing, I would go for lactulose. But if they had given me a scenario of a patient with more prominence on that altered sensorium and what is the next step, then even CT brain is also an option because you will have to rule out other causes. But let's stick on to this one. I'll go for lactulose. Okay, right. Which of the following symptoms suggest the use of steroids in IgA vasculitis? Skin rashes, GI hemorrhage, abdominal pain, arthritis. In fact, options B, C, and D, steroids can be used for all three of them. But the compelling indication to use steroids is often a GI hemorrhage. Abdominal pain, arthritis, you can treat with other modalities as well. Arthritis, you can try with NSAIDs initially. And then if not responding, you go for steroids. Abdominal pain also, you can go for symptomatic management first. But the most compelling evidence for use of steroids will be gastrointestinal hemorrhage in IgA vasculitis. And what is IgA vasculitis? It is your Henoch-Schönlein purpura, HSP, right? Okay. Now this question, again, I've got various versions of this question from students. So I do not know what exactly to answer for this. So I've just put it in one version. I'll just tell you one of the other versions as well. A patient came to the OPD with complaints of headache, lethargy, abdominal pain, and developed recurrent renal stones. Serum calcium is high, PTH is high. What is the likely diagnosis? I'm sure even any student would actually answer this, sir, this is primary hyperparathyroidism. Simple. But the problem is, some students told me that, sir, it was not like this. Serum calcium, some students told me that it was written, it was normal. Some students told me it was low. Okay, I do not know. It is unlikely for a hyperparathyroidism to have a low calcium, right? Unless it is a say a chronic kidney disease patient having a secondary hyperparathyroidism. Okay, primary hyperparathyroidism is not going to have a low calcium. So if that was the case, answer is not primary hyperparathyroidism. Low calcium, again, less likely to be seen in association with a primary hyperparathyroidism. And some students, told me, sir, this headache, no, it was episodic headache. And instead of lethargy, some mention of some neuropsychiatric manifestations were there. Neuropsychiatric manifestations can occur in primary hyperparathyroidism. But again, the point here is that some students were saying that they wrote pheochromocytoma since episodic the headache was mentioned. But again, the other symptoms are not matching it. Okay, and especially with and in that version of the question, the students told me the calcium is actually low. So let's take this version. If this is the version, answer is primary hyperparathyroidism. And pheochromocytoma will not have such sort of recurrent lethargy, abdominal pain. Okay, they are relatively less common manifestations of pheochromocytoma. They would have other features of sympathetic overactivity that is dominating the clinical picture rather than recurrent renal stones. Anyway, it's not hyperparathyroidism, can be easily eliminated. Some students were vouching for mineral bone disease because they said that headache was there, it was decreased calcium and high PTH. Could this be a chronic kidney disease with secondary hyperparathyroidism? Possible, but again, that depends on how the framing was. Okay, so I think I've given you the different versions of this question as well. And since many students were coming up with different versions of the question, that's why I've put this question last as well. But I just wanted you to know that this question was asked for the exam, and you can expect questions from similar topics as well. So that's it. That is the end of the discussion of the recall questions of medicine, INI CET. Once again, I want to emphasize to you that cardiology is something that you have to be very, very strong while you attempt the INI CET paper, because you get good chunk of questions from cardiology, and you've got to be thorough in your ECGs as well, and rhythm abnormalities as well. So thank you so much, everyone, for joining, and all the best.